Thank you. Now I'm going to talk to you about skeletal abnormalities. Now this is one of my favourite topics. I love having a go at diagnosing skeletal abnormalities. Most people find it complicated and confusing and run away from them, but actually if you take a very logical approach, you can get a long way towards making a diagnosis. And as we keep saying, we've always got exome sequencing now to fall back on if you can afford it. So what I'm going to do is I'm going to give you the clues to the diagnosis of a generalized skeletal dysplasia. Then I'm going to give you the approach to the diagnosis of conditions which affect the lower limbs, and then an approach to the diagnosis of conditions which predominantly affect the forearms. And if you think about it in these ways, I think you'll find it much more straightforward. First of all, you need to think about the etiology of skeletal anomalies. Maternal illness, so diabetes, maternal myasthenia gravis can give you contractures, myotonic dystrophy, if mum's got myotonic dystrophy, the fetus can present with talipes and polyhydramnios, and with systemic lupus erythematosus, then you can get stippled epiphyses, and I'll show you some pictures later, which can give you a clue to the underlying diagnosis of an immunological diagnosis in mum. Some maternal drugs can give you skeletal abnormalities, in particular warfarin, again, can give you the appearance of stippling of the epiphyses at the end of the long bones. Sodium valproate, an anti-epileptic drug, can give you radial aplasia, as can alcohol. And of course, recreational drugs, such as cocaine, can give you transverse limb anomalies, as well as a lot of other anomalies. A lot of isolated abnormalities of the limbs can be idiopathic, so no particular genetic etiology, and I will describe that later. And of course, chromosomal abnormalities can, particularly chromosomes trisomies 18 and 13, can be associated with abnormalities of the forearms and, of course, of the lower limbs. And then there are many, many genetic syndromes which have limb anomalies associated with them. Again, the inheritance pattern can be very, very variable, so it's important to make a genetic diagnosis in terms of both predicting prognosis before birth, but also recurrence risks for future pregnancies. So why do we try and make a diagnosis? Well, our objectives in diagnosing skeletal abnormalities are for us to try and improve the prediction of outcome. So for generalized skeletal dysplasias, this is going to be a lethal abnormality or a non-lethal one. And then for other abnormalities, what is the degree of handicap going to be? So diagnosis helps us inform accurate prenatal counselling. It informs further investigations that we should consider doing. And of course, our antenatal ultrasound scan may provide it may provide definitive diagnosis, and it may provide the only information that we have, particularly when parents decline post-mortem. So let's think about generalized skeletal dysplasias. Let's think about the sonographic findings. So when you see a baby that might have a skeletal dysplasia, you need to think about this systematically. You need to look at the long bones, look at the length, look at the pattern of shortening. Is it rhizomelic, so these bones? Is it mesomelic? Are they equally short? Look at the growth pattern, because not all skeletal dysplasias appear early in pregnancy. Look at the pattern of growth. And look at the structure. Is there bowing? Is there, as in this case here and here, you see very angulated tibia here. And look at the ends of the bones for stippling of the epiphyses. Look at the degree of mineralization. This is a really, really good clue. It will give you a clue to a very limited number of diagnoses. And the best way to look at the mineralization is to look at the skull and to look to see whether that skull casts an acoustic shadow, which this one is not doing. And here you can see the eyes very clearly. This is a very, very hypomineralized skull in a case with osteogenesis imperfecta type 2C. You should also, and of course these, because the bones are so poorly mineralized, one of the common referrals when you've got a hypermineralized skull is query ventriculomegaly, because you can see the ventricles so clearly. The other thing you need to do is look at the shape of the skull, be it in the first trimester here. This is this is a baby with thanatophoric dysplasia with the beginnings of a cloverleaf skull in the first trimester, and this is that same baby in the third trimester here. And then you need to look at the fetal profile, because that can give you a good clue, either to look for fetal frontal bossing in some conditions, or to look for micrognathia in others, or in some, a flat face, or in others, the appearance of not having a nose. No, can't see the nose properly because of a depressed nasal bridge. So you can get lots of clues from looking at the skull and the fetal profile. You need to look at the chest carefully. You need to look at it in a parasagittal view here, to look at the size of the chest, and here you can see this is a small chest, narrow chest here with a bulging abdomen. If you look at most of us, we're sort of straight all the way down, but babies with small chests have got narrowing and bulging of the abdomen. I like looking at this view here, where you get the fetal thorax in a cross-section through the thorax at the level of the four-chamber view, and then looking at the level that you would take at the abdominal circumference view, and compare the two. They should be more or less the same. But here you can see this chest is much smaller, and note too, it's occupying a lot more than a third of the chest. So a heart should occupy a third of the chest, and this one is occupying more than that. So this is a small chest. Look at the ribs. Look at the length of the ribs. So this baby has very short ribs here. Again, looking in cross-section through the chest here. And this baby also has short ribs, don't go far enough around the chest, and they're also slightly splayed at the ends here. And then in some situations, if you look again in the sagittal view, you can see the beading of the ribs, indicating multiple fractures, and that gives you a really good clue towards osteogenesis imperfecta. The spine too can give you good clues. It can be profoundly hypomineralized. Here we've got a baby, you see this looks like a railway line really, and the vertebral bodies are just not mineralized, and that's almost pathognomonic of achondrogenesis. So again, you can get a long way towards making a diagnosis just by looking carefully at various parts of the baby. Here you can see this baby has got a very irregular spine, and if you look in cross-section here, you can see that there are rib gaps. So this baby's got multiple hemivertebrae. Here, this spine looks very irregular as well, but actually this is because of extra calcification in cases of chondrodysplasia punctata, and I'll show you some of those in a minute. You also need to look at other features in the baby. So you need to look for talipes, you need to look for contractures, you need to look at the face. Some of these babies with skeletal dysplasias have very small cleft lips. You need to look to see those because that's a good clue. You need to look, as I've said already, for micrognathia, and then all sorts of other anomalies. So many of these babies will have other anomalies, either renal anomalies, genital anomalies, cardiac anomalies, or indeed intracerebral anomalies. So the presentation of skeletal dysplasias varies with gestation, and the first trimester is a really good time to look carefully, and you'll detect many of the lethal skeletal dysplasias and all the features that are associated with them in the first trimester, because you get such good views, particularly of the extremities. So many skeletal dysplasias are associated with nuchal translucency. There are limb charts available from 12 weeks gestation, so you can look at the limb length from early in pregnancy, and as I said, you can get excellent visualization of many features, and I'll show you some examples in a minute. The commonest presentation in the second trimester is the fetus with short femurs and other long bones, and other features will be present depending on the condition. You'll detect both lethal and non-lethal conditions at this stage in pregnancy. And in the third trimester, the commonest presentation will be of polyhydramnios with a short femur plus or minus other features. And again, we get, in the third trimester, we'll be picking up variable numbers of short stature syndromes. So let's consider the first trimester just briefly. So as I said, increased nuchal translucency and generalized edema. Many of the severe skeletal dysplasias, achondrogenesis, and so on and so forth, will present with generalized edema, and it may be quite difficult to identify the limbs and the features. The head shape, the mineralization, the absent or very short long bones will be detected, and look closely at the hands and feet because they will give you a good clue. The most common lethal skeletal dysplasia, as I've said earlier today, is thanatophoric dysplasia, and here's an example scanned at 13 weeks gestation with an abnormal skull shape. Even at 13 weeks, you can see here the marked frontal bossing. You can see the short ribs here with the heart appearing to lie almost outside the chest, and the chest being much smaller than the abdomen. And the bones, again, short. This one's still got slight bowing with the telephone receiver handle here. It is the commonest lethal skeletal dysplasia. It's due to mutations in the FGFR3 gene, and certainly in the UK, what we will be doing to make a definitive diagnosis here would be to take mother's blood and analyse cell-free DNA looking for mutations in the FGFR3 gene. Another skeletal dysplasia, lethal skeletal dysplasia that will present in the first trimester is osteogenesis imperfecta. Now there are many forms of osteogenesis imperfecta, and the sort that I'm talking about here now are type 2A/2C, and this is lethal. It presents with profound hypomineralization of the skull. You can see the beading of the ribs here. This is at 14 weeks gestation. The limbs are very crumpled and often difficult to identify. So here's a bowed femur and a bowed tibia and fibia here. So this is due to mutations in the collagen genes. It usually has a low recurrence risk, but there can be paternal or parental mosaicism, which will increase the recurrence risk. Dystrophic dysplasia is an example, again, where you can make a definitive diagnosis relatively straightforwardly in the first trimester by identifying these hitchhiker thumbs. So the baby has thumbs which look like it's hitchhiking. So hitchhiker thumbs and hitchhiker toes together with short limbs and talipes. This is a recessive condition. So thanatophoric dysplasia is a dominant and new lethal dominant condition, very low recurrence risk. This is a recessive condition, so you need to make a definitive diagnosis. Another condition which can present again in the first trimester, which is viable, as is dystrophic dysplasia, is Ellis-Van Creveld. This has polydactyly in here. You can see the polydactyly of the toes here with short limbs, and you can see that here you can see the limbs are short and how the skin sort of outgrows the limbs. This is a good sign of a skeletal dysplasia. So that's the femur, and here's the tibia and fibia here. And these babies often have heart abnormalities, in particular AV canal defects, and you can see that here. Again, that's recessive. So in the first trimester, if you see a baby which looks like it has a skeletal dysplasia, avoid a surgical termination of pregnancy unless you have a molecular diagnosis. Because you need expert perinatal pathology, and again, because of the variability in recurrence risk, there's a mixture of dominant and recessive conditions here, and the recurrence risk therefore can vary from less than 1% to 25%, and it's important for parents planning future pregnancies to know what the risks are. In the second trimester, as I said before, the common presentation is of short femurs, which can be isolated or can have other features. Either you need to look at the pattern of shortening, look for bowing, look for the chest size again, look at the skull, and look at the spine. Let's just think for a minute about isolated short femurs or isolated short long bones. So no other particular features that you can see. So if you're presented with a baby with short femurs in the second trimester, what should you be doing? Well, the first thing to do is to take an obstetric history for previous babies that have died in utero, for a past history of preeclampsia, of IUGR, and indeed for an abnormal baby. Look at the parents. Are the parents of short stature? Is this a baby that's just going to be like its mum and dad? Has this baby got a chromosomal abnormality? So Down syndrome can present with isolated short limbs. So look at the Down syndrome screening results, but not just for a risk for Down syndrome. Look too for low PAP-As and high HCGs, which may indicate early signs of intrauterine growth retardation. Clearly remeasure the baby, make sure that the measurements that the baby was referred with are correct. Check the dating information, make sure that the dating is done by ultrasound and somebody hasn't just got the dates wrong. Look at the pattern of the long bone shortening. Look at the size of the abdominal circumference and the head circumference. Is everything small, or is it just the femurs? Are the bones bowed or are they straight? And do a detailed scan for markers of aneuploidy and other or skeletal dysplasias. In the UK, we would do uterine artery Dopplers as well in the second trimester, and we would consider karyotyping. In our experience, about 1/3 of babies that present with isolated short long bones, isolated short femurs or short long bones in the second trimester have early sign of early onset IUGR, and I do think you need to think about that very carefully. If there are no markers of skeletal dysplasia, this should be the parents are of normal stature, this should be your first consideration, and you should monitor the baby for IUGR. Now let's think logically, let's categorize the babies that have got other features. So first of all, let's think about babies that have got short limbs and a small thorax. These are the common conditions. There are others, of course, because there are lots of skeletal dysplasias. Once again, we come up with thanatophoric dysplasia, that'll be the commonest, osteogenesis imperfecta, the short rib polydactyly syndromes, Ellis-Van Creveld, and some of the other ciliopathies, Jones asphyxiating thoracic dystrophy, etc., and a lot of other conditions. Thanatophoric dysplasia, again, remember, generalized short limbs. You've seen this slide already. The limbs for thanatophoric dysplasia are short from early in pregnancy. This is a series that we saw, some of them scanned longitudinally at UCH, and you can see this is the growth of the long bones. So short long bones, the femurs are often in the frog-like position, short stubby fingers, this is called the trident hand, a small chest, frontal bossing, and short ribs. A lethal dominant mutation, again, in the UK we can diagnose this on the basis of analysis of cell-free DNA. A low recurrence risk. One of the major differential diagnoses here is short rib polydactyly syndromes, and they don't always have polydactyly. You need to be aware of that. So again, a small chest with short ribs, so this is a small chest compared with the abdomen. Massive polydactyly here, this baby's got preaxial polydactyly. This is can you see here? This is a very small cleft lip here, which you can see the arrow is pointing to the cleft there. A lot of these babies will have CNS anomalies or renal anomalies, and many will have ambiguous genitalia. So there are multiple abnormalities in association with these babies, and sometimes you can't examine the baby very well because of large multicystic kidneys and oligohydramnios. These are all recessive with several causative genes, and you do need to make a molecular diagnosis. This is a situation where exome sequencing could be very useful. Now, spondyloepiphyseal dysplasia congenita is an interesting situation. So here we've got a baby here that looks as if it has a small chest. It has micrognathia. So in the parasagittal view, it looks like it's got a small chest. But when you look at it here, in the cross-section through the fetal thorax, you will see the ribs are of good length, and the heart only occupies a third of the chest. So this baby is not going to die from pulmonary hyperplasia. The limbs are short and straight, and the hands are normal. This differentiates it very clearly from thanatophoric dysplasia. This is due to mutations in the collagen genes again, and it's not lethal, as is evidenced. So it's very important to try and distinguish lethal conditions from non-lethal conditions. And here we see, this is the baby that we've just seen the scan of. This is his dad. This is Warwick Davis, who's quite a well-known actor and comedian in the UK. And he's got 2 children with SEDC, and his wife has achondroplasia. So this is you need to make sure that you differentiate between lethal and non-lethal. And everything that has short limbs is not necessarily lethal. So that's short limbs and small chests, and the reason why the SEDCs have got apparently short chest is because it has a short spine. So it's the short spine that makes it have that appearance. So short limbs and hypomineralization, a limited differential diagnosis here: osteogenesis imperfecta, hypophosphatasia, achondrogenesis, and Greenberg dysplasia. Well, I'm not going to show you the pictures of Greenberg dysplasia. That has massive hydrops and very, very short limbs. So osteogenesis imperfecta, you've seen some of these pictures before. Profound hypomineralization, no acoustic shadow cast here. That's the view in the first trimester. A small chest with this what's called a champagne cork appearance here. Beaded ribs because of multiple fractures. The bones can be really difficult to identify. They can be very crumpled. So this is the lower bone, the tibia here. This is the humerus here, very crumpled, multiple fractures. And this is a postnatal X-ray, and the skull was so soft that it disintegrated at delivery. These are mainly new dominant mutations, but the recurrence risk is about 4 to 5% because of parental germline mosaicism. You can differentiate this from achondrogenesis, which has short, straight, so a hypermineralized skull, but short, straight limbs, and this is the condition which has this very profoundly hypomineralized skull. There are two sorts, there's dominant and recessive, so this is the type 1 achondrogenesis, which is recessive, and this is due to many causative genes. Type 2 is due to mutations in the collagen genes and has a low recurrence risk. But again, here you can see there's no mineralization of the spine here. I hope you can see that. Again, I've told you before there are many types of osteogenesis imperfecta. This is type 2B, which can present in the first trimester, is in a way less severe than types 2A and C. Again, it can have variable mineralization, so this has got, you can see the intracranial anatomy quite clearly here, so it's not got a very well mineralized skull, but it's better than the OI type 2 skull. And you can see here the bowing of the limbs. You often get bowing of the forearms, the tibias and fibulas, and the proximal bones, the humerus and the femurs. The chest is really pathognomonic. This is, again, the heart, the chest isn't particularly small, but the ribs sort of splay outwards slightly, and this is a very classic appearance here. This is a new dominant mutation again, due to mutations in the collagen gene. Although there are some recessive OI types which appear very similar. This is viable, but most cases will die either in the newborn period or at a young age. So we've done hypermineralized skulls, we've done hypermineralization, and we've done small chests. Now let's think about short limbs with stippled epiphyses. Again, it's a short differential diagnosis, but a more complicated one. So here the baby's got a stippled epiphysis here, and here's the x-rays. You can see this extra calcification here, and you can also get disorganized looking spine, and you can see, you might not be able to see it terribly well because the lights are up. But you can see extra calcification around the spine as well. So short long bones, variable degrees of shortening. Rhizomelic chondrodysplasia punctata, for example, has very short humeri, and others have mesomelic shortening. But a classic example of a chondrodysplasia punctata would be a presentation with short limbs, a funny spine, and no nose. And indeed, I was once out of the unit, and one day one of the visiting fellows phoned me up and said, "Lynn, I've got this baby which has got a funny spine, and it's not a neural tube defect. It's got short limbs, and I don't think it's got a nose." Well, I said, just look closely at the long bones. You'll see the stippling of the epiphyses. This is chondrodysplasia punctata. And here you can see the profile, sort of very flat, no nose. They have very depressed nasal bridges here. So again, this is something where you can make a generalized diagnosis, but the specific diagnosis is much more complicated. This is a metabolic disorder largely, and there are lots of metabolic abnormalities which can cause this. And this is a case when you really do need to call your geneticists in and think about how we're going to make the diagnosis. Exome sequencing again, but again there are a lot of metabolic analyses that we can do to help make the diagnosis. Many of these have a high recurrence risk. They can be recessive and X-linked. So again, it's important to make the right diagnosis. So what about other clues? So we've been through the major clues that you can get for generalized skeletal dysplasias, but other clues are looking for polydactyly and syndactyly. So polydactyly, useful for Ellis van Creveld, for the short rib polydactyly syndrome, occasionally for Jones. These mitten hands is a good sign of Apert syndrome. Again, we make that diagnosis based on maternal blood because this is an FGFR2 mutation. And then there are a lot of some of the craniosynostosis syndromes, for example, that are associated with polydactyly. So it's a good clue to an underlying genetic condition. Can we briefly think about short femurs in the later second or early third trimesters? Again, we come back to, have they been measured correctly earlier in pregnancy? Check the pregnancy dating, look at the parental height. Look for intrauterine growth restriction. So again, check the Down syndrome screening results for low PAPA and high HCG. Consider aneuploidy and consider skeletal dysplasias. And the most common skeletal dysplasia that will present in the third trimester is achondroplasia. So here we have the normal growth centiles for normal femur lengths, and you will see that in this series of babies with achondroplasia, the limb lengths only begin to fall below the normal centiles around 25, 26 weeks gestation. And they also have relative macrocephaly. This is a really good sign. So a baby with short limbs in the third trimester and a big head, think achondroplasia. Look for the frontal bossing if you can. Look for the short stubby fingers. Some of them will have short chests, smallish chests, and some can have respiratory difficulties at birth, but not very often. And some of them will have slight bowing of the femurs as well. Many will have polyhydramnios. Again, as I said earlier today, 98% caused by a common mutation in the FGFR3 gene, and we can make that diagnosis based on maternal blood. What else should you think about apart from achondroplasia? Well, you need to go through your protocol for excluding IUGR. So Dopplers, amniotic fluid volume, Down syndrome screening results, look at parents, consider karyotyping, because many of them will be IUGR. Now, I want just briefly to think about abnormalities confined to the lower limbs. Okay, so this is when you've got an abnormality. So if it's bilateral, if you've got bilateral abnormalities in the lower limbs, so bilateral bowed limbs, for example, it's most likely to be syndromic. Think about osteogenesis imperfecta types 3 and 4. Think about campomelic dysplasia, and think about femoral hyperplasia unusual facies syndrome. If it's unilateral, so if you've got a unilateral short bent femur, it's most likely to be idiopathic. The prognosis will be related to that abnormality, nothing else. So isolated short long bones and other think about growth retardation as well. So campomelic dysplasia. Now this is something you can really diagnose on the basis of ultrasound and possibly an IPD. So this condition the only long bones that are affected are the lower limb bones. They're short, they can be bowed, can have talipes. If you look carefully, some have heart abnormalities, they can have micrognathia, and you have sex reversal in about 50% of male fetuses with campomelic dysplasia. So again, in the UK, what we would do would be NIPD for fetal sex determination, and if we found this baby with bent femurs, abnormal genitalia, and talipes, this was actually a male fetus, that would be a campomelic dysplasia. It's due to mutations on the SOX9 gene. It's sporadic with a low recurrence risk. One of the differential diagnoses will be osteogenesis imperfecta type 3 or 4, the mild type 3 and the milder type 4, when the initial bowing of the long bones may be confined just to the femurs. So for OI type 3, you can have bowing of the upper arms and shortening of the upper arms as well. But for type 4, you can just get very slight bowing here of the femur and the tibia here, and the growth will be relatively normal. So, and they will often have normal arms and generalized normal limb lengths. These are both due to mutations in the collagen genes, and again, particularly these can have a very good prognosis. And this baby I scanned 16 years ago, and I talked to her physician a couple of weeks ago in the OI clinic, and she's had one fracture in her life and is growing normally. So it's important for us to understand the long-term history of these things. Most babies with OI type 3 have progressive fracturing, progressive short stature, respiratory problems, and their shortened life expectancy. If you have so that's the bilateral symmetrical bowing of your femurs or lower legs, okay? Now if we think about asymmetrical limb abnormalities or unilateral limb abnormalities, these are usually isolated. This is long bones, legs only. They are not associated with chromosome abnormalities, and the outcome is related to the orthopedic problems. It's the problems that you see on scan here. You should check the spine carefully and make sure you're not missing a mild degree of caudal regression, and take a history for maternal diabetes. We've got a series of babies that we've measured over time, and in general, the growth of the abnormal bone is at the normal rate. so that if a bone is 20% short at 20 weeks gestation, it's likely to be 20% short at term. Clearly, you also need to take into consideration joint function, as that may be difficult in some conditions. But we always refer our babies to the orthopaedic surgeons with the growth measurements, and they're the ones that do the counselling in this situation. I'm going to end by talking about fetal forearm abnormalities. Again, you can do this very logically and get to a diagnosis in many cases. First of all, think about the family history. Is there a previous affected child? Is there consanguinity? Is there likely to be a recessive syndrome? Think about maternal drug history and examine the parents. So fetal forearm anomalies. So Holt-Oram syndrome is an autosomal dominant condition which has heart abnormalities and varying degrees of upper limb anomalies. And so parents can present with very mild features, just difficulty in pronating and supinating their arms, or a mild heart abnormality. And here's so here we are with the baby with Holt-Oram syndrome. This baby's got bilateral conditions here, bilateral forearm abnormalities. But you can be very variable. You can actually just have a triphalangeal, so 3 bones in your thumb can be the only sign. It's autosomal dominant, and again, we know about the gene. Now let's think about unilateral forearm anomalies. So just affecting one side. So if they're isolated, so if you've got a transverse defect or missing ulna or a radial club hand, it's on one side, and there is nothing else that you can see in the baby. It's usually idiopathic, and the prognosis is dependent on the degree of the forearm defect. If there are other abnormalities present, then there's a very high incidence of aneuploidy. So you should think about karyotyping, because again, trisomy 13 and 18 are common here. The other common association is VARTA, so vertebral anomalies, anal atresia, tracheo, esophageal, fistula, radial, and cardiac abnormalities. So look carefully at the spine, look carefully at the heart. Cornelia de Lange is very common, not very common, but it is a common association, and I'll show you some pictures of that in a minute. And then look at the rest of the baby: femorofibular ulnar syndrome, golden hearth syndrome. Most of these are sporadic, and many of them are not genetic, but there are some that are. So this is an example of a VARTA syndrome. This is the forearm defect here, and there's some hemivertebrae here, and this baby also has a mild hydronephrosis. Now, if it's bilateral, and the forearm defect appears to be isolated, look very, very carefully at the heart for other anomalies and examine the parents for Holt-Oram. You can have relatively minor heart anomalies with Holt-Oram syndrome, so it's worth looking carefully. If you've got other abnormalities present, then there's a high incidence of aneuploidy, so do consider karyotyping. And there is a very high incidence of genetic syndromes here, and I'll show you some of them in a minute. In general terms, if this is bilateral, you should really be thinking aneuploidy or genetic syndromes. So thrombocytopenia absent radius, again, this is a diagnosis you can make on ultrasound, because it will have these babies have radial anomalies or have forearm anomalies, but they always have their thumbs present. You can see the thumbs on this baby here. You can have radial and ulnar lesions, you can have short-bowed humeri, you can have bowing of the femora, you can have cardiac abnormalities, renal abnormalities. They're usually symmetrical, these abnormalities, and these babies can have profound thrombocytopenia, so it's worth knowing for management of delivery. This is an autosomal recessive condition where the outlook is very good unless you get severe intracranial the outlook is dependent on the renal on the limb anomalies, unless you get intracranial bleeding secondary to the thrombocytopenia. Roberts syndrome is another condition where you get bilateral anomalies, but these are very asymmetrical. You get varying degrees of oligodactyly, so here's a single forearm bone with 3 fingers here, another 3 fingers here. They often have cleft lips, heart abnormalities, microcephaly. They have severe developmental delay. This is recessive and it's often lethal, so this is not a good thing to have. De Lange, again, you usually have bilateral forearm defects, but they can be very asymmetrical and they can be very variable as well. So you couldn't just have an extra finger maybe, or here you can see the different oligodactyly here, just 2 fingers in this case, 3 on this case. The profile is really quite telling. You have this overhanging upper lip and giving you the appearance of micrognathia here. So you can see that quite clearly in a number of these cases here. You can see that, and particularly in this 3D one here. So you have oligodactyly, overhanging upper lip, micrognathia. Quite a number of them will have diaphragmatic hernia, and most will have intrauterine growth restriction, but that often develops later in pregnancy. And this is due to a deletion on chromosome 3, and it's a new dominant mutation. So, in conclusion, I would suggest to you that if you take a logical approach to the diagnosis of skeletal abnormalities, some of them, definitive diagnosis is possible with ultrasound. But post-delivery confirmation is absolutely essential. I think it requires a lot of time and patience and specialist knowledge and liaison with genetic colleagues. And as I said earlier today, exome sequencing here is something which is going to be of significant help if you target your diagnosis. And this is my dog that has a mutation in the FGFR4 gene.